Hey, so thank you for tuning in to the Functional Medicine Center on YouTube. This is Kate Godley, and I'm here today with Josh Corwin, our physician assistant who performs procedures and helps our patients who are in pain. And we're going to talk a little bit today about what Josh does and his background, how he made his way to the Functional Medicine Center. So, Josh, thanks for taking the time to talk with me today.
Of course. Thanks, Kate.
So I just wanted to start with a little bit of your professional journey. Can you tell
Yeah.
us a little bit more about the 15 plus years that you were in the orthopedic world and as a physician assistant in orthopedics, especially in urgent care and doing post-op visits?
Yeah.
What did you see that made you kind of inspired to move to what you're doing now?
Yeah, it's a really great question. Thanks. I saw a lot of great outcomes with surgeries, and I saw a lot of people that got really good results, but I saw a lot of people that plateaued. I saw a lot of people that had arthritis or sports injuries and had either had surgeries or were not a good surgical candidate. And we reached the end of what we could offer them, right? There was anti-inflammatories or pills. There were pain medications, more surgery, and that was kind of it. And so I thought that there had to be a little bit more to offer people um, besides surgery.
Yeah. And can you tell me a little bit? We shared a patient years ago that shall remain anonymous, but when she saw you, you did a really great hip exam, and you mentioned to her that you thought maybe her pain was inflammatory, that your
Mhm.
instinct from all of your experience in orthopedics was this was not necessarily like a torn labrum or like she was walking and she suddenly hurt her hip. It wasn't a sports injury,
Yeah.
was more of an inflammatory pain. Can you tell us, like, if there's other patients that are like her out there, what does it look like to come in and see you, to have an exam with you? How thorough is that exam? How long does that take you? And then what does the conversation look like if the person maybe has something like Lyme disease?
Yeah, absolutely.
And how did you know?
So,
You know?
yeah. So I'm a firm believer that 90 plus, maybe 95% of diagnoses can be made through conversation and a good physical exam and maybe a stethoscope, right? And so it's just listening and hearing when people describe their symptoms. And sometimes it's very obvious. Somebody will say, "Hey, I twisted my knee. This is where it hurts." And it's a very obvious mechanical issue that's reproducible. You can pinpoint it. And sometimes it's not, right? And so it's just having worked with thousands and thousands of patients. And in that person's case, who I think I know who you're talking about, um, I had examined thousands of hips at that point in my career. And I knew from what she was describing that it did not seem like a mechanical issue. It seemed that it was a whole joint. It didn't seem like her whole hip was a problem. And it wasn't isolated to uh, one part of the cartilage or one part of the joint. And I said, hey, this doesn't seem like it's not adding up, right? And there's this tendency especially in orthopedics, to make a diagnosis, right? A firm, clear diagnosis that you can say it can be algorithmic at times. And my job then, and my job even more so now, is to say, hey, let's make sure that you're not an algorithm and that we're actually hearing everything, right? And so when you come in to see me now, it's very different than a typical orthopedic experience. And I try to make it clear to everybody I am not practicing orthopedics in my role here. I'm an integrated physician assistant, and so what I offer people is consults where I say, hey, bring all your X-rays, bring all your MRIs, bring all the notes you've had elsewhere, and I will go through it with you, and then I will talk about what I can potentially offer that's non-surgical and that is not an orthopedic surgery for you, um, and go from there, right? So I block out about an hour of time, usually a little bit more for the first visit for a musculoskeletal consult, which is going to be very different than your typical orthopedic setting, which is usually a 3 minute to maybe 10 minutes if you're lucky visit. All right, I block out an hour of time and we start by hearing everything, right? And I will start dialing in and in my head and saying, what do I think makes sense? What do I think is going on? And then ask people, hey, what do you think? Or when you saw this person, they told you that, did that feel right to you or did it feel wrong? And really listen to patients' intuition about what's going on with themselves and come up with a diagnosis or two or three diagnoses, right? And what I have found over the years is that people are misdiagnosed often, right? That's the biggest takeaway that I left conventional orthopedics from. And that's not to say I'll never work in that realm again. I have a profound respect for orthopedic surgery and appreciation for it. But the sheer volume of patients that people are seeing, people get misdiagnosed and they don't get the time or the space to hear everything, to give all the information properly. And so they come here, we talk usually for 30, 40 minutes before I ever lay my hands on somebody. And then just like in conventional orthopedics, or just like most practitioners that have been doing this for a long time, you usually have an idea what's going on with somebody before their exam, right? But your exam sort of serves to back that up and to validate that, or for me to say, hey, this is not what I thought it was. Let's dig deeper and let me find out some more information, right?
I
And
think
so my exam, yeah.
I think from the patient's perspective, you're saying, you know, be wary of going into a clinic visit and they tell you you need surgery right off the bat and their exam doesn't take that long and the visit doesn't take that long. Just be a little bit skeptical and get a second opinion, right?
Totally.
Because
Yes.
that patient that I had sent you was recommended for surgery of her hip.
Mm-hmm.
And it turns out she actually had systemic Lyme disease since birth. She was in her 30s. It was finally really, really, really bad.
Yes.
And the Lyme treatment, which was very hard, and she got through it, but the Lyme treatment over a period of a year and a half is actually what got rid of her pain.
Totally.
But you know that because you've taken the time to follow up with people where their pain wasn't going away. And we have the time now because we are not accepting insurance, right?
Yeah. I mean, that's the thing. It's all about time.
Yeah.
Right. And that's part of why my decision-making process in my career was to become a physician assistant rather than an orthopedic surgeon, is because I don't want to say anything negative about surgeons, right? I've worked with some really caring surgeons who are really great people, great providers, and thorough. But I've worked with surgeons who are not that, right? And
if
so
I'm in a car accident and my femur's coming through the skin, I want the guy who can fix the femur.
Sure.
You know?
Yeah, absolutely. Yeah. And I've had patients that have come to see me for consults, and I will say to them very honestly, hey, I can't help you. I really think in my experience, based on my experience, that you should have the surgery, and here's why, right? And here's somebody that I've worked with who I trust with my family members, right?
Right.
And so I will never steer somebody away from surgery if I really in my heart think it's the best fit for them. But yeah, I mean, so it's specifically about being able to pinpoint when something is inflammatory or infectious or is not a typical problem. The bulk of it is just listening, and the bulk of it is really hearing the nuances there. And I won't bore you or anybody that's going to watch this with stories and on, but there are people that have come in more than I can easily remember at this point that have walked into an urgent care setting that I was working in and coming in for back pain, and me saying, and winding up referring them out to for an infectious disease workup, or I've diagnosed with Lyme in an orthopedic clinic setting, or with inflammatory disease like ankylosing spondylitis.
Right.
Just because I've always been willing and insisted on being able to take the time to slow down and listen.
Yeah. Yeah. And like you said, that's the benefit. You've almost been like a little bit of a spy for a long time. You've been in the operating room, with a lot of different surgeons. You've seen if someone has degenerative osteoarthritis of both hips, what hip replacements can do in terms of giving them back their quality of life. So you have a good unbiased view of where the surgery is great. And then when people are offered surgery, when maybe they should be offered systemic Lyme treatment instead, right? Is that an accurate? kind of
Very
summary?
much so.
Yeah.
Yeah. I mean, there are some surgeries that I've assisted in over the years when they go well and it's the right patient, right fit, right recovery, where it is instant gratification. And 3 weeks after surgery, someone's coming in tap dancing and they couldn't get out of bed. Their pain was so bad, right? When surgeries go well, it is amazing.
So in the office, if you're looking at their MRI, let's just say
Yeah.
take hip pain, for example, and
Yeah.
somebody has hip pain, if you're looking at their MRI and you're spending at least 40 minutes listening to their story, I think it's safe to say that they can leave the office knowing that you've taken everything into account and that if you're recommending they have a hip replacement, it's for good reason, right?
Yes, very much so. So my hope when I perform consults for people and I offer a consultation is that they leave here empowered. They leave here feeling very educated, right? Part of what I do is I'll pull up their X-rays and pull up a normal X-ray. I'll pull up an MRI, pull up their MRI, or I'll pull up an animation that shows it. I want people to leave here being like, oh, now I understand what this is.
Yeah.
Now I actually feel comfortable having surgery. Or hey, now I don't want surgery. Now I want to do Wharton's jelly treatment with you. Right.
Yeah.
I yes, I care about people moving forward with me because this is my practice and I love the patient care. But really what I care about is that people are empowered to make their own best decisions for their own care. Right. And so if someone had people that have left here and said, hey, I had surgery with Dr. Bob Smith, who you sent me to, everything went great, or my mom did great with this, thank you so much. To me, that's just as good as me helping them.
And so you just mentioned Wharton's jelly. So for people who don't know, what is a Wharton's jelly injection?
Sure.
Because the goal we're talking about is pain. We're all on the same team to get people out of pain. Me, you, Sophie, that's what we're trying to do. The orthopedic surgeon up the street, the pain management doctor
Yeah.
up the street. But I had a patient the other day, for example, who was going to pain management, and I said, "What are they offering you?" And he just said opiates, right?
Yeah.
And so, what would be? Can you think of an example of someone who would be a good candidate for Wharton's jelly injections, and what are they?
Yeah, absolutely. So Wharton's jelly is a, a jelly or a jelly-like liquid that is found in umbilical cords, right? So there are three blood vessels that are in umbilical cords, and the Wharton's jelly is this jelly layer that cushions and pads and protects everything inside the umbilical cord. And for millennia, it was medical waste, right? Or it was just disposed of. And researchers actually started looking at this and found that it is filled with all sorts of great stuff, right? And I don't want to just rattle off a bunch of things, but there's some things that are really important, right? So we know that Wharton's jelly can contain mesenchymal stem cells, which are the kind of stem cells that are undifferentiated, meaning they can become anything. They can become a new liver, they can become a new piece of cartilage, they can become any kind of tissue. They have not differentiated and become anything yet. So they can have that potential to regenerate damaged tissue within the body. Wharton's jelly also contains a ton of growth factors, particularly TGF beta, which is transproliferative growth factor, and VEGF, which is a vascular endothelial growth factor, which are two growth factors that are massively important for tissue regeneration and tissue creation, right? There's also a bunch of other things in Wharton's jelly, like collagen, hyaluronic acid, um, tons of other things. I don't want to just rattle off scientific names
Yeah.
just to confuse everybody, but basically, it's all about that provides cell attachment and cell regeneration here, right? And so, how that relates to what I do here versus traditional orthopedics is that traditional orthopedics for something like knee arthritis, right? One of the most common forms of osteoarthritis or bone arthritis that there is, and knee replacement is the most frequently performed joint replacement surgery around the world. Okay? So traditional orthopedics involves having people come in, diagnosing them via X-ray, maybe offering a cortisone injection, steroid injection, same interchangeable terms, offering them an oral anti-inflammatory pill, something like Celebrex or Advil, ibuprofen there, right?
Mm-hmm.
sending them to some physical therapy for strength and muscle conditioning. And if that worked, great. If that doesn't offer relief, then the conversation switched to hyaluronic acid injections, which may or may not help people, right? And then the conversation is, if that's not working, and people talk about bracing and putting on a big bulky knee brace, then opiates for pain medication. And if that doesn't work, knee replacement, right? And so there are tons of people that, for a multitude of reasons, don't want or cannot have knee replacement, or just simply don't think it's the right fit for them based upon their own research and education. And that's where orthopedic surgery traditionally has left people by the wayside, right? There was nothing else other than pain medication and continuing injections, which usually stop working after a while, to help, right? And so where Wharton's jelly fills that gap potentially is that it is the only thing out there that has been shown to potentially regrow cartilage or to potentially regrow some of the damaged tissue, right?
Yeah.
And so what my process looks like here for something like knee arthritis is to have people come, we look at the x-rays and we look at this and figure out, are you a candidate? How bad is your arthritis really? Usually people have an idea because they typically have been to orthopedics already. And can Wharton's jelly or any of the other treatments that I offer here potentially help you?
Mm-hmm.
And I treat them.
And so would you expect them to notice improvement in one treatment?
So it depends upon which treatment we're looking towards, right?
I'm talking about just the Wharton's jelly.
Yeah, so with Wharton's jelly, I definitely expect people to get improvement in one treatment. It is not instant gratification, right? It's not like when you've gone for a steroid injection and 24 to 48 hours later, you're like, oh, that feels relief. It's not like taking an anti-inflammatory pill where you get relief in an hour, right? The point of Wharton's jelly, what we're trying to accomplish is biological regeneration. And so an analogy that I give to patients all the time is, think about when you've gotten a bad cut or a bad scrape. And it usually will stop bleeding pretty soon. But how long does it take you until it heals over and then scabs over? The scab may come off in pieces a couple of times, and then you have a little scarred, and then the tissue around there will still look a little bit pink, right? That's biological healing, and it takes 6 weeks, right? And so it's typically, to answer your question directly, typically I see about 6 weeks to 3 months of time before people get improvement from Wharton's jelly. With that said, I've had outliers that I've been blown away by, right? I had a woman who was, I think, 47 at the time, who had anterior or front-sided knee arthritis, where the front of her knee was crunching, something that we see very frequently. And the data shows us that it occurs more frequently in tall, thin-frame women, more so than any other population, right? So you have this patient comes in and she's did tons of sports in her younger years, was a runner, and her front side knee pain and knee crunches. She can't get up. She can't go up and down stairs. I did Wharton's jelly for her, and she came in a week later and said, my knee's great. It feels perfect. Do the other side. And I remember saying, hey, that's impossible. It's placebo effect. And she said, you can't placebo effect that it's not crunching anymore.
Yeah.
And right. And I said, I don't know what to make of it. And so she goes, do the other side. I did the other side for her. And I saw her 3 weeks after that. And she said, feels great.
Yeah.
So this is somebody I took care of. So I haven't caught up with her in a while. This is somebody about maybe 4 or 5 years ago that I took care of. I had seen her at 1 year mark and then at 2 years. And I knew out at the 2 year mark, she was still having zero pain in her knees and she'd gone back to all activities there.
That's great.
Right?
I mean, from my perspective, I'm trying to prevent cardiovascular disease and osteoporosis in those same women.
Mm-hmm.
And I need them to squat and I need them to lift heavy weights in order to build muscle and build bone. And so if you can get rid of the arthritis in their knees, now we're actually going to save their heart and save their bones. And that person later on is so much healthier too. Right.
Undoubtedly. Right. Yeah.
So what can I just ask though, what made you offer Wharton's jelly? And when would you instead offer something like PRP with ozone? Because
Yeah.
The Wharton's jelly is the most expensive thing we offer. Is there a patient you would see where you instead offer PRP with ozone in a joint?
Yeah. So I would tend to use PRP, which is platelet-rich plasma, right? It's a process where I have somebody come in, I draw some of their blood, spin it down, and I get rid of the red blood cell layer or the white blood cell layer, treat it, and I prepare, and I just harvest the plasma layer that has all the platelets in there, and it sort of activates all the growth factors that are naturally occurring in our blood. And I then take that and inject it with some ozone gas along with some other numbing agents, and I put it into the area. In this case, we're talking about a knee, right? So there's no evidence that I've seen, both in the data and in my own real world experience, that says or shows me anywhere that PRP can regrow cartilage, even when I add ozone to it, which does amazingly beneficial things, right? And so my conversation, if someone's got mild arthritis, it might not be mild or even moderate arthritis. It might not be that regrowing cartilage short term is the best approach for them. It may be that eliminating their pain via PRP and ozone is a much better option there, right?
What about Traumeel, which is the homeopathic
Mm-hmm.
anti-inflammatory?
Yeah. So Traumeel, I like to present it almost similar to a cortisone injection, right? It's a plant-based anti-inflammatory. It's got 9 different homeopathic reductions of plant-based anti-inflammatories there.
Mm.
I have, over the years, injected about 20,000 body parts, which I know is a staggeringly ridiculous number, but I actually did the math one night and figured it out and went back. About 20,000 body parts with steroids, and at this point, something like 2,000 plus body parts with Traumeel. And I have not had one person who has had an adverse reaction to Traumeel at all. Whereas with cortisone injections, they work well, but they really have profound side effects. They're not supposed to have systemic effects.
They can.
But they do, right? They do often, right? And I won't go down that whole path. But so Traumeel is a plant-based anti-inflammatory that I use for acute and chronic inflammation, right? If someone has a knee that gets sore from time to time and they know they have arthritis and they just want a little quick tune-up, Traumeel is great for that. It works wonderfully in combination with lidocaine for trigger point injections. So if someone's been doing a ton of desk work, or if they are having just that tightness in here that we all deal with, or up and down their back, I can use a solution that I mix up of Traumeel and lidocaine, and just really, I realized over the years that I say funny things. Like I was catching myself saying, "Oh, I just sort of paint the spine, right?" But or paint the back over there. But what I mean by that is I just sort of will find by palpation and feel where all the trigger points are, and we'll take the tiniest needle, usually a 27 gauge needle, and just put it right into where that little spasm is and get a little twitch, and then inject a little bit of Traumeel and lidocaine in there. And doing that provides a ton of relief, right? And so
it reminds me of chiropractors and physical therapists that I know that do dry needling. And I was talking to this patient who, again, was just given opiates from their pain management. And I said, does your pain management doctor do trigger point injections? And do they do PRP injections in the joint for pain? And they said no. And I said, I don't know why they're in pain management, to be honest. They're just giving you systemic opiates that cause constipation as well as addiction issues. And so that's not, in my opinion, a good way to get rid of pain for good. Right.
Yeah, fully agreed. And I'm not. I find you probably find this too. I find that I'm walking this tightrope in conversations with patients, with colleagues, of saying, I don't want to dismiss opiates, right? I don't want to dismiss antibiotics. I don't want to dismiss this. They all have a role and an appropriate place here. And I'm classically Western medicine trained, and I've worked for I don't know how many 15 plus years, right? I believe in the conventional medicine, and I see it working, but we're using it the wrong way, right? Plain and simple.
And it's not a binary. Like like allopathic medicine is bad and integrative medicine is good. It's just what's appropriate at this time for you and why, right? I
Yeah.
mean, if I have terminal breast cancer, I'm going to take all the opiates,
Of course. Yeah.
to be
Well,
honest.
here's a really good example. I had somebody here maybe last week or 2 weeks ago, and it wasn't obvious exactly what the issue was, right? I wasn't totally convinced if it was localized pain
Where was
in
the
the hip bursa. It was out sort of towards the side of their hip, right? And I wasn't totally sure if it was referred from their back, we call radicular pain, or if it was coming from their hip directly, right? And so I said to them, hey, I want to do a little experiment if it's okay. And I just used a little bit of lidocaine and I numbed the one area right into the hip bursa directly, which is superficial. It's on the very outside of your hip. If you've ever been standing, you lean up against the wall and you can sort of feel that little sore spot that sticks out in the prominence of your hip. Um, that's the bursa area right there, right? And I will say, I told them I'm using this diagnostically and hopefully therapeutically, meaning if I numb you right now and we'll sit and talk and grab a cup of tea while we're waiting, and 10 minutes from now you can stand up and you can do a rocket high kick and the pain's gone, then I know diagnostically I've figured out the issue here.
which is what?
Because
What is it if you numb?
if I then I knew it was a trochanteric bursitis, right? Meaning that the bursa of the hip was inflamed here, and then I can treat that, and then I can say, great,
Right.
I don't need to send you to go get an MRI of your spine. I don't need to give you Valium because you're claustrophobic to get an MRI.
Yeah.
I don't need to send you for aggressive physical therapy for your spine, although it'll help you stay flexible and mobile. But I can treat this exact problem here without needing to drive up your costs, without needing to drive up your time. And right here, right now, I can do this for you. So that was somebody that I did PRP with ozone for, which has been shown to work beautifully for trochanteric bursitis, and did it for him, and it was a one and done. His pain was gone.
What about rotator cuff? Like, I'm having this right-sided recurrent rotator cuff issue. Do
Yeah,
you think PRP with ozone would help me?
I do. Who are you going to find to do it for you? Uh,
Um,
you
is
know,
it
so
is it better for soft tissue maybe than the Wharton's jelly / stem cell stuff?
Yeah, so PRP works beautifully for soft tissues, muscles, tendons, ligaments, bursa, fascia, things like that.
And go ahead.
It historically doesn't work all that well, in my experience and in the literature, and some people may argue differently. But I don't see it working all that well for arthritis,
Right.
profound
Right.
arthritis, right? I think that it'll dull down the ozone will help to dull down the pain, but I don't think it works all that great. So I don't push PRP with ozone for arthritis.
But if you have a little rotator tear, like a supraspinatus, it might actually help the healing there.
Um, no,
Maybe.
the jury's out on that one,
Okay.
right? There's historically and right in the conventional orthopedics, rotator cuff tears, anti-inflammatories, physical therapy, and then surgery. And for ever and ever, people have been told, and I told people over the years, hey, there's nothing other than surgery that will repair rotator cuff. And I don't think there's a great mechanism for PRP to repair rotator cuff longitudinal tears. I think if there's a like tendinosis where the tendon is just really inflamed or really bad tendinitis, 100% PRP with ozone is the way to go for that, right?
I think you can
Um,
tell that when you're taking the history, though, because
mhm,
my pain's not constant, right? So
right,
it sounds more like a tendonitis than it does a tear.
mhm,
Obviously, an MRI would help you,
right,
but I think the tendonitis is the inflammation of the tendon, and it comes and
mhm,
goes, right? Or am I getting that wrong?
totally. No,
Okay.
that for sure. Yep. And
And it can be
so
excruciating one day and then be totally gone for a day, and you're like, what did I do to make it better?
totally. Yep. Yep. That's a really great point. And that's a really good uh, history point, right? And I don't want to say surgeons I work with aren't going to hear that, But if somebody says,
They're, they're in
Josh,
so much of a hurry, it's hard to listen.
right,
Yeah.
exactly. If somebody says to me, hey, I can do this most days, but then today I just can't. But I'm like, wait, yesterday you can do that? And he goes, oh yeah, yesterday I can do that fine.
Yeah.
Almost proven that they don't have a full thickness tear of their rotator cuff,
Right.
because when the rotator cuff is fully torn, you cannot move in the plane where the tendon is pulling your arm, right? And so,
And and so what about trigger point injections? Like, a lot of patients have trigger points in this upper trapezius area. If they're also having shoulder pain and a tendonitis, could you do both at the same time? Will you do trigger points and a joint injection?
for sure, yep, absolutely. And
It sounds like
we
you're saying you're going to customize what you're going to do based on the person's history and then their physical exam.
completely,
Yeah.
it's all customized. It's based upon um, severity of pain. It's based upon what people's activity levels are. It's based upon um, yeah, I mean, it's based upon a multitude of factors, but it's never the same thing twice, and I will always try to present something to somebody in the way that, hey, I want you to know everything that I know and about this here, so we can be on the same page. Like, can we try this? Right? I had a patient 4 weeks ago who was having shoulder stuff, and I just did not think it was his rotator cuff, or I knew he was having a lot of pain there, but I really thought it was more uh, likely a biceps tendon issue in the front.
Mm-hmm.
And he said, yeah, but said, no, I saw it. But his MRI, he came with an MRI in hand. His MRI showed the rotator cuff was inflamed. And I said, yeah, but it's not, doesn't seem like what it's bothering you. So same thing. I know this is the second time in our conversation I'm mentioning diagnostically trying lidocaine, but it's not something that I do a ton of. But this person was like, hey, let me try this. And I numbed him in the biceps tendon sheath with lidocaine and put a little
Mm-hmm.
Traumeel in there. And sure enough, in 10, 15 minutes, he goes, oh, yeah, it feels really good. And I said, okay, here's the anatomy. The bicep is totally distinct and separate from the rotator cuff.
Great.
If we've numbed within the tendon sheath of the biceps tendon and your pain is eliminated, we know that's the issue. Right. And so I
And it's
said, great, we're going to
possible.
try this. Yeah.
I think your rotator cuff might even become inflamed if you have swelling or pain somewhere else, because then you're holding your arm in a weird way. Is that accurate?
For sure. It's
Yeah.
all it's all posture, it's all neck, right?
Yeah.
And I know this, from all your years of teaching yoga and just from your own personal work to stay strong and weight lift and stay flexible and be athletic, right? But it's all connected, literally and figuratively, right? Um, so you can, and I part of sometimes my diagnostic exam with somebody is I will have them stand and do a full external rotation, really, where you pull your shoulders all the way back and
Yeah.
externally rotate there. And I will ask somebody to do that, almost over exaggerate. And they say, as you do that, do you notice a change in the pain? Right. And they say, oh yeah, this is sort of resolves over here. Right. And for me, it's not 100% of the time, but for me, if I can change somebody's scapula and pull their scapula back and reduce the tension on the trapezius, and this changes, to me, that indicates it's more coming from your neck and muscle and soft tissue than from the shoulder proper, the shoulder joint.
Yeah.
Right. And so, I can torture people and torture myself with here's the name of the exam, here's the tendon, and all that. But it's just that I've been doing this for decades, and I've examined thousands and thousands of people, and I'm sort of notoriously an observer, and I just, whether I want to or not, just observe patterns and things. And so I see patterns, and I think that's something that I took for granted as a provider, that I realized over the years that not everybody has that.
Sure.
Right? I just see patterns, and I'm like, and I almost like you remember something you saw in a TV episode 3 seasons ago. I'm like, oh wait, I remember this, and this from 12 years ago, and I just will pick up and have this intuition that this is where the problem is.
Well, what I encounter is that there are providers in family practice medicine where they're taking insurance in the
Mhm.
traditional orthopedic clinic, in the pain management clinic, that are experiencing their own burnout. And it's hard for them to really observe because they don't have enough time.
Mhm.
And, to be honest, if they haven't gotten answers for their own pain, it is hard for them to find answers for their patient's pain.
Yeah.
Um, and so that's where I think everyone I know who works in integrative medicine or regenerative medicine got there through their own journey, right? Um,
Undoubtedly.
so I want to do another video where we talk a little bit about your journey with your own pain, because I think when we're talking about pain, people feel a little bit overwhelmed because they've had it so long in many
Mhm.
cases that they don't really think there's any hope for an answer. Um,
Mhm.
and one thing that we do really well here is give people hope again.
Yeah.
Um, and so I want to talk a little bit about why we're so compassionate to people's pain. It's really because we've been through it ourselves with our own autoimmune disease and our own
Yeah.
inflammatory, you know.
Totally.
Uh, but just to kind of finish up with this conversation, what about IV ozone? Because that's kind of different than everything else we talked about so far. But I know I
Yeah.
refer patients to you for IV ozone when they
Mhm.
have terrible fatigue. The CDC calls it um, MSIDS, but it's basically like multiple systems causing fatigue. So
Yeah.
hormones aren't working right, their immune system's not working right. We know in
Yeah.
many of those cases, we find Epstein-Barr, long COVID, Lyme disease,
Mhm.
Bartonella, Babesia, sometimes things like parvovirus or lichiosis. But all of these infections are what have caused their fatigue.
Mhm.
Can you tell us just kind of off the record, like what you've seen, what you've observed when people that are really fatigued I do IV ozone treatment with you?
Yeah. Um, I, I mean, the results or the changes that I've seen in people who've gotten ozone have been profound, right? I've had somebody who was dealing with chronic and persistent brain fog who could not recall something they had eaten for breakfast or conversations from a week ago, or really anything pertinent, and did IV ozone for them. And it's sort of a running joke, and I think you probably remember who I'm talking about. But um, she and her husband were leaving to go out to the beach after their IV ozone, and her husband called and said, "I don't know what to do. She won't stop talking." And I teasingly said, "That's a good thing, right?" And he's like, "Yeah, but you don't understand. She's talking about stuff that happened 5 years ago, stuff that happened 10 years ago. Something in her brain unlocked, right? She's total clarity, and she's remembering things, and she is." And I said, "Great, right?" And so,
How long does
um,
that last? Like, how long did you observe things like benefits like that lasting?
yeah, it's variable, right? I think that in order to get the benefit, well, let me back up for a second. It really depends upon what's causing the issue, right? Because if it's an infectious process here, ozone can definitely modulate a lot of that and give your body resources to fight that off. But unless you fix the underlying issue, right, it's not going to be a permanent solution here, right? So I will say that the first, I typically have people come once a week for 4 weeks when they're starting the process here, and typically once a month thereafter here, right? And then the follow-up question to that people always say, well, what about for this diagnosis, or what about for that diagnosis, right? And I make it very clear that ozone is not FDA approved for a particular diagnosis, right? Like Tylenol has been FDA indicated and has an indication for knee osteoarthritis. There is no FDA indication, right, for ozone, right? So I can't and won't make claims that I'm treating a particular condition or a particular diagnosis here, right? All I can really tell people is that here's all the stuff that ozone does with inside the body, which, and the correlation is that people with a particular condition usually feel better because they
Right.
usually have the yeah.
And
Um,
I'm sure you see this too, but there are patients that have Epstein-Barr virus reactivated I know you and I have both dealt with that in our lifetime. They've
Sure.
they've got COVID antibodies that they're not clearing either because they had vaccines or COVID, or they were just exposed to COVID. They never actually got it, which sometimes is even worse.
Right.
And then combine that with their nutrition, their stress level, their cortisol, their environment, what toxins they're exposed to. And so everybody ends up being actually an individual. And I, even with this, with the same labs with Epstein-Barr and COVID, I don't treat them the same, right? Because they
Yeah,
respond to things differently, you know?
totally. Yeah. I mean, I had a patient who was seeing a functional medicine provider at a different practice, and their provider, somebody that I had known forever, and referred her for ozone for Epstein-Barr. Right, she's having chronic Epstein-Barr. Again, questionably whether it was reactivated from COVID, um, and we had lots of data points for her blood work. We looked at all of her Epstein-Barr titers there, and she'd done all the appropriate stuff from the functional medicine perspective to try to dull down the Epstein-Barr, and she was still just dealing with it. So we did baseline labs, and she was somebody who, just because she's really into the science on it, every single week, before we started her ozone therapy, I drew a tube of blood off of there and sent out her markers there. So we had basically,
Epstein-Barr early
yeah, for Epstein-Barr,
antibody.
yeah, for Epstein-Barr, yeah, antibody, and we just watched it and then looked, and she came in at the 1 month mark or for her monthly treatment, and we did it again, and the levels came down, right? And so I make it clear that we know in science we have to talk about causation versus correlation, right? And I have not done a randomized double-blind study, so I'm not going to make claims. But she done all this other stuff, right? What else was it? Yeah.
You know, and Josh, my pet peeve is when people talk about evidence-based medicine and they don't allow you to include your clinical experience. There's actually a really great article on this that I can post with this video, but there's a lot of things that will not get funding for really big randomized controlled studies, especially when we're talking about things that aren't going to make anybody money, right? IV
Yep.
ozone isn't going to make anybody money. Vitamin C, eating blueberries every day isn't going to really make
Yeah.
any. The blueberry farmers have not yet unionized to pay for that study. So
Yes.
so we have to also share what we've seen clinically. It's really important. The patients are really asking for this information.
Yes.
And at this point, our clinic's been open for 8 years. I think you started doing IV ozone in 2020, right? So you've seen a lot of people come in here in wheelchairs and walk out. You've seen people with long
Yeah.
COVID do really, really well.
Yeah.
I think it works best from what I've seen for neurological symptoms,
Yeah.
fatigue, and that really heavy, like that, like body fatigue that people get. Would you
Yeah.
say that's
Well, I
what you?
mean, for sure. So there was a, believe it or not, a 16-year-old super smart researcher in Canada, right? And he just started looking for stuff, and his data point found that everybody with the diagnosis of chronic fatigue syndrome had a low level of 2,3-DPG, right? So
What's that?
2,3-D, right, you're right. So 2,3-DPG is an enzyme that, and I am not going to pretend that I am a microbiologist here. I just have studied this stuff over the years enough to understand it, right? I'm not a researcher, but 2,3-DPG is an enzyme that basically catalyzes the release of oxygen from within the hemoglobin molecule, and it basically accelerates the rate of Krebs cycle and your body's ability to produce ATP.
Make
Right.
energy.
So exactly. Right.
Yeah.
So that's Krebs cycle is how our body makes ATP, which is what we use for energy within all of our cells. Right. And so this basically teenager kid in Canada said, "Hey, I've gotten 150, I think was the number, something like that, number of people diagnosed with chronic fatigue syndrome. I found that all of them had measurably low levels of 2,3-DPG in their blood. IV ozone directly stimulates production of 2,3-DPG within the body, right?
People.
It unequivocally increases the rate of and increases the efficiency of cellular metabolism and mitochondrial function."
And correct me if I'm wrong, but as the ozone is working, because you're pulling their blood out, is it about 400 milliliters, or how much blood are
Yeah,
you
just a little bit less. So
taking?
I take out typically about 350 mLs of blood.
And it's hanging in a bag.
Yeah.
And as you're putting the ozone in, it's very quickly becoming O2 and then an O minus, which is an oxygen radical.
So it's a free oxygen,
Yeah.
but which is helpful. But the biggest benefit is that it forms peroxides, specifically really short chain peroxides that have sort of been nicknamed ozonides there, right?
Hmm.
And it's really the peroxides that are causing the benefits here within the body, not necessarily ozone directly. Ozone directly can and does have the ability to kill bacteria and viruses there because there's an enzyme that is missing from the cell walls of those cells that is present in human cells. So that it basically causes instant cell wall rupture, which is why ozone can be used as a really potent disinfectant commercially because
Ah.
it right? Because
And
it
so
can
it might be killing these tiny spirochetes
right.
that cause Lyme disease called Borrelia too.
Right. Yes. Yep. There's great theory with that, as well as the ultraviolet light array that I use. So as I'm taking your blood out, it passes through an ultraviolet light array where it gets exposed to ultraviolet A and ultraviolet C light spectrum, and that has also been shown to uh, kill bacteria, viruses, spirochetes there, right?
And
Um,
we've done a few talks with the patients that are on the YouTube channel about chronic viruses, chronic bacteria versus acute,
mhm.
right? Your immune system goes into a really terrible, dysfunctional, inflammatory picture if you've had a virus more than a few days, more than 8 days.
Yep.
So,
Yep. Absolutely. And we were talking earlier about clinical experience, right? And so I all I can do is tell stories, right? Without having funding to do a full back study here. I had a patient in the earlier stages of COVID when people were being hospitalized and dying in high numbers, right? And amazingly, I know you know this, but everybody listening at home, we treated a lot of people in the practice here, right? I mean,
over
and
a
that
thousand,
yeah, and
probably
not
closer
one
to 2,000. Yeah.
and not one of those patients was hospitalized.
Even
Okay.
patients that were in heart failure when we saw them.
Yeah, I mean, I had a patient, and this is in the middle of that first winter there, maybe December 20 or January 2021, and I was doing ozone for people out in the parking lot, and I had somebody who I remember came in. They had 103 plus fever, O2 sats were 91, like just in bad shape, and was not going to do well, and and I did ozone for them and gave him a little bit of IV fluids at the end just to try to hydrate them a little bit. And his wife called 2 hours later and said, "Hey, his fever broke and his O2 sats are coming up."
Yeah.
Right? I
I
I
saw
have
that
no.
over and over. Yeah.
What's that?
I saw that quite a few times. I'm thinking of three people in
Yeah.
my head that
Yeah.
I am really sad to think that if they'd gone to the hospital, they wouldn't have made it. So
Yeah.
I'm really grateful that you were willing to do IV ozone on these patients.
Yeah. And I again, we don't have a study that says that ozone can treat COVID,
I mean, we've been
but
doing
I
it for 5 years, so I think we're allowed to observe.
yes, but I can observe, and I do have evidence as to what reactions happen in the body, in the blood, from ozone therapy and from the ozonides that are created there.
Yeah.
So
So we think it probably helps your immune system clear the infection, but it also may be directly helping get rid of the infection.
yes,
It's not just things like COVID and Epstein-Barr. I think we've seen it help a lot with Bartonella, which can cause OCD, can cause ADHD, can
yeah,
cause anxiety. A lot of my
yes,
patients that have had tick bites have Bartonella.
yes,
Um, I don't want to get into too much more because I don't want to make the video too long, but I
yeah,
think without having that tool up your tool belt, it would have been harder to get some people better, that have come in. And it
yeah,
can be used as an adjunct. It sounds like you already said that. Patients can also see you for IV ozone without seeing me or Sophie. I want to make sure that's
correct.
Yeah.
Yep.
Do you do some
Yeah.
sort of screening of new patients that are coming in to see you for IV ozone because they're really tired?
Well, yeah, I mean, I will always do the first time I meet somebody, I have them fill out their history in terms of why are they coming here, and then I will do a heart and lung exam, right? Because I need to make sure that when I'm taking out somebody's blood, that they're not going to be so fatigued from it that they're going to pass out. Now, granted, I put it back in very quickly.
To be clear, we're putting it back in within a few minutes. Yeah.
Yes, I put it back in within a few minutes, right? Um, and also the amount that I'm taking out is if I were to lose somebody's blood, which thankfully has never happened, I'm not taking out enough that I would have to send somebody to get a blood transfusion or have it blood replaced or anything like that. It's probably about 3 times the amount that you typically get drawn for when you're getting blood work done.
How much does it equal what you'd give if you donated at Red Cross?
So Red Cross is a little bit over a pint. Don't quote me on this. I have to double check my math. I think a pint is about 473 milliliters, something in there. Do you have a Google in front of you?
Yeah, 1 pint is 568 milliliters. So you're doing
568.
significantly
I was
less.
way off. Yeah,
You're doing way
and I'm
less.
I'm
Yeah.
taking 350. So it's at about 2/3 of a pint. Yeah.
So less than
Um,
you would donate safely.
yes. Yeah, I'm taking 2/3 of that amount,
But
right?
again, we're putting it right back in, and the blood that you're getting put back
Yeah.
in, you can even see that it's like a bright red color. It looks like
Yes.
healthier blood.
It gets instantly bright red from the hyperoxygenation there, right? Yeah, and I know we don't want to take too much more time there, but there's a list, and maybe I just need to make some good slides that we can link to where I just sort of talk people through this here. But there are just a whole myriad of reactions here, right? So, ozone, there's a whole long list of immune mediators there, but ozone will directly stimulate the release of both interleukin 10 and TGF beta 1, which have been shown to downregulate um, your immune system, right? So in people that are having autoimmune disease, ozone can dial back the immune system, but not turn it off, right? We're not
Yeah.
talking about decreasing your ability to fight disease. We're talking about to decrease the mediators that are causing an overstimulation here, right? So that's one way that it is probably helpful for autoimmune disease as well.
Yeah. Yeah. I remember doing a paper in grad school on interleukin 10 and how it actually reduces inflammation. Because a lot of people think all of the cytokines are bad, but half the cytokines are good.
Yeah.
And it actually, interleukin 10 actually increases something called T regulatory cells, which are amazing to turn off autoimmune disease without making you immunocompromised. Because remember,
Yeah.
we are trying to offer things here that are a little different than what they would offer at the conventional rheumatologists, where they're just offering biologics like Enbrel and Humira and prednisone, because those things can turn off too much of the immune system. We're trying to tamper down the autoimmunity without turning off your ability to fight new infections. So I think that's pretty clear. And I also think, more research needs to be done on the immune system because what we understand is so small compared to what we
totally. And I know you are an immune expert times 10 compared to my knowledge of the immune system here, probably times 100 if I'm being honest, right? But there's great science out here. So right, you can read this now, and it's not just
conjecture
floating out there. Yeah, it's not just conjecture, it's actually published data, right? So they've now do studies here, and we see that, like, one thing I remember clearly is that ozone, a little bit of oxidative stress from ozone activates NRF2, right? Which is a cytoprotective factor here.
protein. Yeah.
Yeah. And it literally causes it gives your body the ability to serve as free radical scavengers, right? So you do ozone, it increases NRF2, you now have free radical scavengers, and you can literally go and bind free radicals, and then your body can clear them here, right? It's literally activating existing tissues here to let your body function better, right? We're not adding drugs, we're not adding chemicals, it's the opposite of that. Yeah.
And again, it's not a binary. Like, there's plenty of times when people come in right now with Epstein-Barr, and I'm actually offering them off-label usage of prescription pharmaceutical antiviral for Epstein-Barr, but they can do that and come see you for IV ozone. They complement each other. Similarly, they were doing research on IV ozone for HIV and for Ebola.
Yeah.
And both of those research topics were shut down by the pharmaceutical industry. So
Yeah.
I think the point is we're in a place in our environment of patients come in very well educated, and the internet exists for people to go read about studies going on in other countries. And so it's a really good time to be helping people with their fatigue and their pain and their chronic illness, because
Mhm.
we can use whatever is appropriate today for that person.
Yes. And I
Kind
think
of
that
fun.
our climate, both nationally and internationally, right now, that I think COVID was a big precipitator of this, but I think that there's a lot of attention and a lot of focus on things that historically have been squashed by big pharma, right?
Yeah.
And so
People are
yeah,
listening to Dr. Paul Merrick talk about vitamin C for cancer. Finally,
yeah,
we knew vitamin C treated cancer in the 1970s. We knew it
sure,
certainly was not going to hurt anybody to take it, right?
yeah.
Um, yeah, it's
So,
very,
and this is an anecdote I've told in elsewhere, but I just want to mention. So, in the 1940s, there was a dentist in Sweden who figured out and he treated another physician who had gangrene of his jaw, and they treated him, which historically resulted you would cut out the gangrenous section and leave people with no face and hope that they survived, or people would die from gangrene, right? Pretty basic medicine. And they figured out how to treat people using ozone. Nikola Tesla invented the ozone generator in 1896. It had been used at that point for 40, 50 years. They were treating gangrene. The dentist and the surgeon who was treated wrote a book, and they brought it to the US and they were bringing ozone here. And then penicillin was invented, and the then head of the AMA lobbied the government to say, "Hey, we don't need ozone here. Let's get rid of this. We don't need this here." And to my knowledge, it's the first example of big pharma or big medicine lobbying against something because there was big money in penicillin there.
yeah, you have to be skeptical when somebody's
Yeah,
going to make money by squashing some research.
yeah.
Yeah.
And yeah, to your point, Columbia in 1991, they found ozone was not curing HIV, but was effectively treating HIV.
It
Yeah.
was basically helping people build their T cells again and just give
Yes.
them, it's almost like a stopgap. So we're
Yes.
not saying they wouldn't take the HIV medicine. You know, this is
Right.
where I started my career. So I'm very passionate about helping
Mhm.
people with HIV, but it is a chronic virus. So eventually it does throw the immune system off kilter. And
Yes.
people are not dying of the virus itself. They're dying of the side effects of the
Yeah.
cardiac inflammation or the brain
Right.
inflammation from having inflammatory markers high for so,
Yes.
you know.
But ozone predated AZT, and ozone was working to stop people from dying of AIDS when nothing else was, right? And then Big Pharma came out and said, "Hey, we've got AZT." And as you've taught me over the years, AZT was a step in the right direction, but it wasn't until triple therapy came around that people can live and survive with HIV, right? And so they said, "No, we've got AZT. We don't need ozone. Thank you very much." And again, it was squashed. And so
Yeah.
um,
Be
it's
suspicious.
happened repeatedly, and I just hope that the momentum continues, or that patients that are watching this know that there is a ton, decades of experience in this practice, and that we care about science, and that we care about research, and that we care about efficacy, and we care about safety, and that
Mhm.
ozone is extremely safe and effective for helping people.
Yeah. And the interesting thing is that we've each had our own experiences with family members with autoimmune disease where they were not treated um, quickly or correctly in the conventional system in the hospital.
Mhm.
And at the time, like back in the 90s and early 2000s, you and I did not have the training and experience yet to intervene and say, hey, let's try some things that have zero side effects that might help you.
Yeah.
And so we've learned from that because we lost those people, especially our grandmothers.
Mhm.
And I think the great thing is we've now spent, like you said, like 20 years just kind of gathering data. And now when patients come in, we can say, here's what we've seen here, here's what we've seen here, and summarize quickly what our experience has been. And obviously that's just our viewpoint, but people tend to gravitate to us both in our personal lives and here at the clinic that
Yeah.
have really interesting kind of rare autoimmune symptoms.
Yes.
So like
But
we're at dinner parties and we're meeting these
you'd say
people.
interesting. I would argue they're not rare anymore,
That's true.
right? And I don't want to go down a conspiracy theory loophole, but I think there are a lot of things that we're doing environmentally, which I know you've studied for
Yeah.
years and years and years, right? There are things that are in our environment that are causing autoimmune disease in profoundly high numbers. It's not complicated.
The way I describe it regarding our oldest child who has type 1 diabetes is maybe just the virus that they got before the diagnosis would not have caused the type 1 diabetes. They had to have the genetics. They had to have some toxin exposures, have mold exposure, and live in a world full of plastics and pesticides, right? So it was a combination of things that all came into play. But the great news is we do actually know what triggered it. And that means that we can give patients treatments to prevent them from getting another autoimmune thing and another autoimmune thing, and then early dementia, and then early stroke, early heart disease. These
Yes.
things we can prevent now. So
Yes.
exciting.
So my last thing I'll say about when you talk about prevention, right? Ozone causes oxidative stress in the body. However, ozone is a dipolar molecule, meaning simply it has a positive and a negative, right? And so because it has this magnetic potential here, uh, it will it cannot form free radicals in a water-based environment with a pH lower than 8, right? So all that to say,
So the
in the
blood.
human body, you will not find in anybody who's alive, you will not find the pH greater than 8. Everyone has a much lower than that, 6.5 to 7.5, right?
Yeah.
So simply free radical formation cannot occur with the appropriate use of ozone here, right? So this is the hallmark reason why when everybody says, well, we want is antioxidants here, it's important to mention that ozone is actually an oxidative treatment, not an antioxidant. But in this case here, it does not form free radicals that we typically see with oxidation, right? And so free radicals are the problems that cause heart disease, that are causing cancers, that are causing Alzheimer's, that are causing Parkinson's disease, all these profound autoimmune disease here. They are not caused by ozone. In fact, the opposite is true, right? And so it's important when we talk about prevention here that when people do their own reading here, people will try to debunk here, and it's a lot of propaganda, in my opinion. But they'll say, "Oh, well, you don't want ozone; it's oxidative here, right?" You have to understand that bad oxidative stress causes free radicals and disease. Ozone does not, right? It's a
Right.
really really important
And that's a
point.
great example of how things work in the human body can be very different than in the petri dish or by themselves.
Yeah,
So cool. Well, thanks for sharing a little bit of your scientific and clinical knowledge. And we'll chat again soon about your personal journey. But it sounds like you're really excited to be offering both the treatments for pain that we have, which again is the PRP with ozone, the Wharton's jelly, trigger point injections, Traumeel,
yeah,
and then also the IV ozone with UV therapy, just to try to,
yes.
I don't know if the best word is boost your immune system, clean up your blood, however you want to describe.
Yeah, I have some information on our website, and I will probably ask anybody that wants to know more about the science is to head onto our website there, and I'll probably make another video that I'll label ozone ozone science for brainiacs and really talk about this in depth in here. But yeah, I definitely hope that anybody watching today has gotten a really good overview of how it can help treat your pain and how I can help your immune system and chronic infections.
Yeah, I think it would be great to kind of talk about what a 10 pass is versus a 5 pass versus what you're doing. And then
Yeah.
what is extracorporeal blood oxygenation and ozonation. And that would be a really good article for people that want to dive into the science more.
Mhm. Yeah. Yeah,
Cool.
for sure. I've got a lot about that, but we'll end this for now.
Yeah. Thanks for your time.
Thanks, Kate.